This is Dr. Bess Miller, and I'm here with Dr. Dale Lawrence. Today's date is April 6, 2018, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I am interviewing Dr. Lawrence as part of the Oral History Project, The Early Years of AIDS, CDC's Response to a Historic Epidemic. We are here to discuss your experience during the early years of CDC's work on what would become known as AIDS. I must ask Dr. Lawrence, do I have your permission to interview you and to record this interview?
Yes, you do.
Thank you, Dale. You were one of the original members of the CDC AIDS Task Force on Kaposi's sarcoma and opportunistic infections, as it was known in those early days, put together ad hoc in the summer of 1981. Your background as chief of the Human Leukocyte Antigen Lab in the Clinical Immunology branch of the Immunology Division, later named the Division of Host Factors, and as medical epidemiologist in the Division of Host Factors, made you a unique member of this task force with an understanding of cutting-edge aspects of laboratory-based and clinical immunology. You eventually came to focus on investigations of cases of this syndrome in hemophiliacs, patients who had received transfusion of blood and blood products, and cases in spouses or partners of these cases. But let's begin with your background. Would you tell me about where you grew up, your early family life, and then where you went off to college?
Yes, happily. My parents were from northern Kentucky and East Tennessee, respectively. They both had rural family backgrounds and some considerable culture from that community, music and education. But none of them had gone to college, neither of those. They married in the Great Depression and moved to the metropolis of Cincinnati, Ohio for employment, particularly for my father. And some years later, I was conceived there. And unbeknownst to them at that time, my history with infectious diseases began quietly in the sense that I was living 2 blocks and playing within 2 blocks or nearby a histoplasmosis outbreak endemic, hyperendemic zone. So I know to this day that I have residual of that, and fortunately not clinically manifest, but quiescent. And that and other childhood awarenesses of personal and family infections keyed me, I think, toward an infectious disease career. I had the opportunity as a 6th grader to be accepted to a competitive college prep public high school, which had a 6-year unified curriculum. This high school had a reputation since the late 1800s of putting out people with stardom in early Hollywood or tennis, or in fact, ultimately Stanley Prusner, 2 classes ahead of mine in the prion science era, and many others. And so we each felt an obligation to try to exceed. I uniquely happened to meet a classmate whom I liked, a friend, and she, by a miracle of coincidence, was none other than the younger sister of CDC's Dr. Kenneth Herman. And in fact, she told me to go check with him if I had an interest in medicine or public health, that he was working for this place in Atlanta on the then epidemic of rubella, and I should go check with him about what he thought of where he worked. And in fact, as they say, the rest is history.
So where did you end up going to college and then medical school?
I joined many of the other graduates of Walnut Hills High School who did not go to the Ivy League colleges, which was very traditional, or the small Ohio or other colleges. I went to the University of Cincinnati, which had a formidable program in chemistry, being the home of Procter & Gamble and other major science and engineering firms. So I majored as a Bachelor of Science in Chemistry, and together with a colleague or several, we studied toward a BS in Chemistry. But after 3 years of that rigorous curriculum, I was ready to go on to medical school and maybe use that year some other time in my life for some sabbatical-like experience, and ultimately that did happen at Oxford. I was accepted to Duke after 3 years and then joined some other UC and amazing colleagues at Duke, where I was introduced to the world at large, the international health dimension, the field of epidemiology, and mentored by a professor, Hans Lowenbach, former chair of psychiatry, who directed me to investigate schools of public health and a career in public health, because I could make changes in society that would, and changes, of course, perhaps to personal medical care, that would help me work out the pain and grieving that had occurred after my uncle became an industrial accident invalid for the rest of his life, for which medical science and research could do nothing. That was my major proponent and prompting to go on into public health.
Wow. So for your public postgraduate training after medical school, it looks like you did so many interesting things. You want to mention a few of those?
Well, yes, I was frankly motivated by three fields: research in the mechanisms of human biology, under which circumstances I started to take a research training program at Duke in what we'd call today tissue or antigen differentiation. The other rival thought was public health on a community level, and for that, international public health appealed to me, or maybe community public health in the inner cities that I had seen. And the third was just excellent health care for the marginalized and underserved or international suffering populations. And that particular one came to win out in some respects. So I got to go to a mission hospital that Duke supported in Nicaragua. I got to see cases of diseases, be it malaria, diarrhea, dysentery, tuberculosis, Pott's disease, diphtheria, you name it, and we had it, trypanosomiasis, Chagas disease, and so on throughout the Americas. And that, plus my fellowship and internship residency in San Antonio and at the nearby military medical centers, introduced me to the POWs coming back from Vietnam. So I had a very intense classical disease clinical encounter.
Fascinating. It looks like you also, maybe this is part of the research, were interested in genetics, immunology, laboratory work. Did you get a chance to explore some of that before CDC?
Well, yes, I suspected my my future would be, as CDC gave me the opportunity to rehearse my infectious diseases skills toward the boards in infectious diseases, which I ultimately got, as well as internal medicine. As that generalized activity in Miami-Dade, Florida, rounded me out, I had already decided that if I could contribute to the CDC and its research arm through integration of clinical epidemiology and community epidemiology with human genetics of immune response, a big new area then, a part of cellular immunology, that I would have a niche and contribute in ways that my other colleagues like Jim Hughes and others were doing in their own fields of enteric disease or whatever. And so I came to CDC interested in that, having had 2 graduate courses. I had studied textbooks of this and talked to people working in that field. I talked to Carlton Gajdusek and others who were doing studies in Papua New Guinea. I was, in fact, I was nominated to come to CDC after a deferral for a purpose of hepatitis B vaccine work. Interestingly enough, already started by the time I got here and done well by Don Francis. But at the time that was new, it was Australia antigen that Bernard Baruch had identified. So there was a field of World Health International anthropology and disease detection that I wanted to be a part of. So that was what I was raring to go when David Sencer said, go to work for the clinical immunology lab. Go see Irvin Kagan, Shirley Madison, both in parasitology division, avant-gardes, and then Dave Gordon.
So just stepping back a tiny bit, how did you come to CDC initially? There was academia, there was CDC. You came in through the Epidemic Intelligence Service. Right. This was in 1973, right in the middle of the Vietnam War.
Right.
Did that have an impact? How did you actually decide on government and CDC?
I don't think I imagined a career in public health for the federal government when I was facing, as all of us rising medical school graduates were, the Vietnam era draft. I had actually taken 2 years of Army ROTC basic training at University of Cincinnati. At that time of second year finishing, I knew I wanted to go to medical school after 3. The Army advisor said, don't enroll in advanced corps. If you walk out, you'll be drafted. And in fact, another EIS colleague some years later told me he was drafted immediately as an enlisted person when he did that. Nevertheless, I didn't choose that hazardous path. I went on to medical school without finishing Army work. But that factored importantly into my comfort level to work around and with Army and military people, uniforms and regulations and rules and customs. And that served me well both in my later training years at Walter Reed, on the staff at Walter Reed, and on my training years under General William Moore in San Antonio, Texas, and Colonel Ledbetter at the Air Force Hospital nearby at Lackland Hall. So I am glad I had that 2 experience, but I knew federal public service was more my likely destiny. And indeed, after 2 years at EIS, sponsored by some famous people that I'm grateful to, and support by Ken Herman, CDC's Lyle Conrad, and of course the incredible Robert Sherrar, who was then selecting candidates, this offer came through, and so I chose it instead of Army or Navy.
Mm-hmm. And so, again, those first few years you had a field services assignment?
Right.
How did that come about, and how did you enjoy that? That was the more generic
yes.
EIS experience.
Well, the selection process, as you know, in the spring was, in my case, fraught with a number of considerations. And one of them was belated at that time, very fresh with me at the time I arrived. My mother had just been diagnosed with disseminated breast cancer, and we knew the end was not too far away. So instead of my speaking with Lyle about Puerto Rico and Hawaii and American Samoa or somewhere far distant or overseas postings, he was very appreciative that I needed to be near major medical centers. So that factored into his and my match for a field services in the continental U.S. where I could fly back to Cincinnati. Ultimately, I worked so intensively in Miami-Dade, both with its senior chief, Milton Saslaw, and Dr. Joel Nitzkin, that they supported me through this period of bringing my mother to Miami, her death there, the time I had to take off for resolution of her estate, and so on. And I must say the state epidemiologist and Lyle and others, like Carl Western, enabled me to have not only get married on my first weeks of EIS to my still wife, Trudy, but also to have a brief honeymoon, and their understanding of the lives as well as the profession of EIS officers was crucial to my sense that this is a place I want to work. They have family values. They have professional high aspirations.
Do you remember what you worked on in Miami?
Oh yes, of course I still have copies of most of those files. It was a eclectic thing. We were wrapping up a typhoid epidemic in the migrant labor camp south of Miami near Homestead. We were wrapping up a cruise ship outbreak that people like EIS officers like Jim Tenney, Mike Merson, and Jim Allen and others had worked on. I then got my own dose of that with some extraordinary cruise investigations. And so that was the biggest part of my EIS. But it included Haitian immigrants with filariasis and malaria and an extremely famous, wealthy scion of a family who were affected by the sinking of the Titanic. And the last survivor of that had a very interesting phenomena from eating raw beef tartare. So it was just everything all over the map, and I'm grateful to the wild and woolly experience that represented.
So now, then you did, tell us what you did after that. You got some experience in genetics research and clinical immunology. How did that come about?
Well, the mapping of the world's human polymorphisms, as we call them, the not just haptoglobin, but which exact molecular structure of haptoglobin could now increasingly be immunologically or immunochemically detected, and those are inherited. And therefore, if you knew the markers that people carried, you began to see their ancestral relatedness. And if they shared diseases in common or were dissimilar with respect to diseases and outcome of infections, then we sought for markers that would distinguish and collaborate the disease susceptibility versus disease resistance. And I mentioned about the Aboriginal experience with opening the doors to hepatitis B identification. And that was kind of a microcosm of many other investigations going on. So my wife was an anthropologist dealing with health issues, and she was doing her own field work, and I decided that after my CDC, 2 years, I would want to propose that I take on this area, which might lead me or us someday to overseas postings and field trips and investigations. And if you can identify, as you so well know, the population who is at most risk of something, then you can understand the unique response they have to, say, live polio vaccine. If they develop paralytic disease and others don't, then you can specify which item is the contributing or major dominant factor. And those were the kinds of diseases we anticipate doing, assessing why some people get lepromatous versus borderline or tuberculosis leprosy, why people get the poliomyelitis paralysis associated with their first receipt of Sabin live polio vaccine, though attenuated. And on and on and on. Tuberculosis, cavitary tuberculosis, Reiter's syndrome after enteric diseases. All these we were engaged in ultimately, but the South American expedition, David Sencer, allowed me to go as a in-kind contribution to a National Science Foundation field trip to Amazonian populations. That really gave me specimen material, field collection materials, and ultimately traveled to the lab benches of Oxford to bring back to CDC both the specimens and that immunology expertise.
So now, how did you connect with David Sencer, and was he instrumental in starting an immunology lab at CDC?
Yes. He, of course, was a pluripotential or a Renaissance person, and accompanied by great humor, of course, and personal touch. And I've been pleased to hear other people's experience and recollection about that. And
So was he director at the time?
he was indeed director at that time. As I arrived here, he was just dealing with the storm of the revelations of the Tuskegee experiments, which of course factored into the research of ethics that I did in later years at NIH. But the awareness of that came to his attention and in his corrective action in 1972-73. And so as I arrived, he was very much the director. He took a very great personal interest in the things that division directors, branch chiefs were in charge of. They were very investing of responsibility in the field officers or the investigative young officers. And so every time a cruise ship had an outbreak, and I think I boarded 18 ships in my 2 years, not for pleasure cruises, shall I say. And during those 2 intense days or nights aboard coming back to a U.S. port, worked with Mike Merson or the laboratorians, Joy Wells or others, to get everything we needed and all the questionnaires and personal patient, that is, travelers' specimens and crew specimens, sometimes not very pleasant experiences for either of them. But those were collated on the same afternoon the ship unloaded at the dock, disembarked. And David Sencer wanted to be the one to say, yes, that ship may sail, or no, we don't feel it's safe enough. And that yes or no, thumbs up or down, would cost the ship in those days $1 million or more by my analyses presented at EIS. Today, it would be a $10 million or $20 million decision. But he wanted to be there. So he was on the phone with Gene Gangarosa and others to make that decision. And the quarantine station staff, I can't have enough praise for in their ability to support these and help me analyze them on the floor and on the tabletop, sorting the questionnaires quickly.
So that's how you got connected to Dave Sencer?
Yes, he got to know me very well and I guess trust my analytic and investigative talents. So when I came in the end of my first EIS year and said, I think I want to stay here, could I maybe do a preventive medicine residency with a goal to integrating immunology, cellular immunology, which is the new field, 3 years old really, and genetics, which is only 1 year old. And he said, go off to your conferences that you want to go to on your own. But next year, we're going to have you meet and deal with these people, and I think you'll have a nest in the clinical immunology lab or division. And that's where I was welcomed and further trained, as I said.
So can you say a little bit more about CDC's interest in immunology and lab immunology? Was that competing with NIH? What was the aim there to try and get expertise in that area?
Well, NIH was, of course, at the front of immunology research, as were many, or let's say a few dozen avant-garde places in the world at that time. The ultimately Nobel Prize for immunogenetics work was won by 2 investigators, Zinkernagel and Doherty, whom I got to know. And before that, immunogenetics and cellular immunology by other investigators of that early era. David Sencer was open to new ways in which CDC could be at the forefront of having the resources to carry out its mission in the epidemic interception and control. So when people on his staff, be they Bureau of Labs with worldwide Supreme Court-like analytic capability for microbes, who could who had advanced a immunology diagnosis of parasitic diseases. When they had new techniques, he supported them. A discovery I made, perhaps about the time I came to CDC, was that there were 3 different parasitic disease expertises. One was clinical diagnosis, and you found these in schools of tropical public health and so on. Then there was the histopathology, and that was at the Armed Forces Institute of Pathology. And then there was the molecular characterizations beginning on the actual microbe. But it was CDC who had the diagnostic parasitology using immune methods. And the handful of the immunologists, primarily from parasitology, said, let's have a weekly meeting and have presentations, a journal club. And so people with leprosy background like Charlie Shepard, Tom Spira, Stephen McDougall, of course Dave Gordon, the head, Irving Kagan, Steve Snow, many people, including vaccinologists, would come and listen and present to that. So we were a kind of a chomping at the bit group, ready for what turned out to be HIV. We had those CD4 and CD8 markers. We were already using them. We had the $500,000 FAX4 machine, fluorescent activated cell sorter, that was a major purchase authorized by Dave Sencer, and then ultimately Dave Gordon, and perhaps by then Bill Fagey. But we were well equipped to be right at the top when this outbreak occurred. We didn't have to get resources and start learning.
That is just so interesting. Well, let's move on then to your work on AIDS and very exciting aspect of it that you got to be involved in. So on July 16th, 1982, there was an MMWR on 3 hemophilia patients with pneumocystis carinii pneumonia. Again, we didn't quite have the cause of the disease, had not been identified. And that first case had been reported in December of '81. You were involved in investigating these cases. Can you tell us a little bit about these investigations?
Those investigations followed the pattern that CDC tried to emulate over its recent decades of history, namely to work through state health departments and local health departments, and the local health departments work through clinicians. If there's a step or oversight or bypass at some point, try to connect the dots again and get everybody on board and get this evidently interstate disease dealt with here at CDC. And we became then the resource, the go-to location for assimilating, accumulating, and then investigating these cases beyond what the state or local health department could do. That meant putting state-of-the-art immunology resources in their hands and at the beck of the clinician if he didn't have that or she didn't have that. Sometimes those clinicians, and not at the very beginning, but some of the clinicians were very academically oriented and wanted to publish their novel case and didn't really want to share much with CDC other than what it took to get medicines for the disease from the Parasitic Disease Drug Service that our Division of Host Factors then controlled. And so when those reports would come in and we realized there was someone kind of coming in the back door for that on a responsible clinician's basis, we would then backtrack and try to fill in those gaps and then get permission from the state health department and keep them informed as we went out and investigated that. And a whole pattern then emerged of an extremely rapid turnaround time. Bruce Evett might hear from it from the Parasitic Disease Drug Service. He'd let the task force know, they'd record some tentative information, then he'd call me in, or he'd call Janine and me in. Janine Jason would then maybe be the one who'd tell me, and we would take off on, or I would take off on a field trip. And
So now the drug in question was,
mostly pentamidine. There were some other drugs that were needed for other opportunistic infections, but for the most part, the necessary drug that would treat the acute pneumonia form of Pneumocystis carinii, now Pneumocystis jirovecii, was in fact pentamidine. And I might add as a parenthesis, our own EIS colleague, now the assistant director for NIAID in Bethesda, Dr. Carl Western, was in fact the originator of that, the implementer of that in the late 60s, I think it was. And so
implementer
of the parasitic disease drug service. He was a parasitologist. And so we are building on incremental elevations over decades of credibility established by CDC, of international commitment, such as Bruce Winiger evidenced in Thailand, the worldwide outreach to Africa, for example, or the Americas, presentations in Europe, Australia, Canada, and so on. I came in with a relatively focused and remarkable opportunity, but I was interconnected with and supported by immense resources and history.
So now the request comes in for pentamidine, and how was it connected that these are hemophiliac patients?
Well, the requesting physician, or if it if the notification was a death in a hemophiliac, or simply an illness in a hemophiliac for which maybe no drug was yet appropriate for that illness, those two pathways, whether going up through State Health Department from a clinician or coming into the Parasitic Disease Drug Service and retrograde notifications, they came to CDC, needed investigation, and so as I mentioned, those intermediates that I worked for would ask me to get out there and see the case, perhaps while still alive, perhaps verbal.
Now,
perhaps
was your group looking at blood issues in general? Why clinical immunology and division of host factors for
in the unfolding history of the clinical immunology lab, after a departure for academia and private practice of Dr. Gordon, Stephen McDougall rose. And I had been initially asked in the summer of '81, when the first MMWR article came out, by Dr. Gordon to get involved, at least informally, because he thought my mix of epi, tropical medicine, opportunistic infections, ID, laboratory immunology, bench work would help. And it, of course, did in the long run. But I took a backseat to persons such as yourself and Harry Haverkos and others who were flying around the country and doing things appropriate to that unfolding stage. I was in the lab doing some studies that later had been published by immunogeneticists on susceptibility to one or more of the manifestations of what we'd call HIV infection today, including the unique Kaposi sarcoma. So as I was doing lab work but going to those, I was staying informed. And others who were attending in that early day, like Dr. David Morans, now of NIAID, were also quite, taking careful notes and so on. When the case in Miami, Florida, was brought to my attention of a hemophiliac who by then had died, who was quite elderly and whose use of factor concentrate had been heavy and as long as it had been available. He was up in years, probably then younger than me, and he had developed an immunologic syndrome that didn't quite fit our case definition, was very close, had no other explanation for immune deficiency, and the astute clinician epidemiologist, senior dean in that community in Miami, Dr. Aaron Krantz, said, CDC, I think this is an AIDS case. And that link of hemophilia and AIDS followed the report through Tom Spirit to Bruce to me, and then I really went to work in it because I knew the clinician and the family.
Say a little bit about what was involved then. I think that finding, that report, was a watershed event for us at CDC and the country to understand a new aspect of how AIDS is transmitted.
As often happens with, so to speak, watershed events, you don't fully appreciate what you've got in hand until the second or third or beyond cases occur, and now suddenly a pattern is emerging. So we were wrestling with what had been a immune deficiency, but with a follow-on immune manifestation not typical of AIDS, which can be a signal of a different pathway of pathology. So we were sort of holding that case in abeyance until June 15th, approximately, of 1982, when Bruce called me and said, you've got to go to Colorado. We've got a case in the ICU there. They've called for pentamidine. He may not be alive much longer. Please try, if he's not on a respirator, interview him, talk to his wife. I raced out there, and that became an intense week-long investigation that has been chronicled pretty well by the author of the book and the band played on, Randy Schultz. And in there he describes how I tried my best to interview him. I did not wear a spacesuit during that because I already had faith in the CDC's experiences with this, that this was not an easily transmissible transmissible disease. I got all the factor concentrate records from that person and 60 others. I put them on a giant spreadsheet, all the blood work, clinical studies, factor concentrates, talked to his wife. Tragic story of I think, a heroic woman who had married a greatly invalid man whose only employment for the family was as a janitor with his handicapping conditions of crippling arthritis from his lifelong hemophilia. I saw them as heroes in their own right, collected, of course, blood specimens and so on with permission, and brought that information fully to the attention of the Hemophilia Treatment Center, whose records I was borrowing or recording, and clinician, and ultimately back to CDC. A similar trip went to Ohio only 3 weeks later, over July 4th weekend, Northern Ohio. Harry Haverkos, my colleague, flew out for another Ohio case. And then there was a St. Louis case that led to me going to a family over a late night trip through the southern Illinois rural areas to a farmhouse with 10 grieving family members, 9 of them adopted children and 1 the wife, and racing those specimens back to the airport. It was just a mind-boggling, cascading, intense event where you knew you were making history and you had to do it right at every step.
Now, at that time, again, we don't know for sure that it's an infectious agent. It's still about a year away from the French identification of LAV, although there was a lot of work that was being done that was pointing in that direction. What was your thinking? What was CDC thinking then as you're seeing these cases in hemophiliacs?
As has been said by others, we all felt that training in infectious disease, experiences such as CDC and academic world and international historians had seen, that it was entirely possible to have a early exposure and a very much later, say 2, 3 or more years, latency of a disease that had begun a bit earlier in a quiet, silent, unnoticed setting. So hepatitis B is, for famous for this because of its 3 or more week incubation period, but then, of course, hepatocellular primary cancer of the liver can occur years and years later, as has been mentioned by many people. But I personally felt even more strongly it was infectious disease, not only because we had the models of hepatitis B and certain conditions like syphilis, where tertiary or even secondary syphilis may be months to years after the primary infection that might have gone unnoticed or certainly unreported. I had worked in leprosy already, both lab work and clinical work in epi. So 7-year incubation period for Mycobacterium leprae was not at all a surprise to me. I had met the man who worked on Kuru. My wife had introduced me to the anthropological thing of Kuru in Papua New Guinea, where cannibal diets of the 40s and 50s led to neurologic dementia and paralysis. So I was open to a long incubation period disease, and so all of us felt, I don't think we can really characterize it, we felt. But what I had in hand that was dramatic to me was the Colorado hemophilia spreadsheets showed that many of those hemophiliacs, though not at all yet AIDS cases, had lymphadenopathy already for months and months and had declining T cells, absolute T cells, for 2 years.
Now, was that on the sheets that had been documented?
Yes, but it hadn't. There was a sense that there is no other therapy that can come close to being effective, fast, efficiently administered in the home, for example, like factor concentrates, is not labor intensive to administer and has been approved by FDA for the requisite heat treatment that manufacturer has been approved for. So we're watching this unfold. We know each of these patients, practically all of them heavily treated, are hepatitis C positive because though not identifiable as an agent yet, we knew it wasn't hepatitis A or B.
Okay.
We knew there was hepatitis C throughout the population, so we worried what shoe was going to fall next.
Okay.
And we felt it was falling, but what do we do? There's no agent. Is it even AIDS? And many immunologists felt there was no such syndrome yet.
How come?
Well, they were, to name a gifted and generous, kind academician, Dr. Robert Good, it took the International Congress on Hemophilia, I apologize. It took the International Congress on Immunology in 1983, a triennial meeting, for him to hear the immense accumulating information before he said, maybe this isn't just a concatenation of different, in fact, even late presentations of congenital acquired immune deficiency. It can't be a unified syndrome, but he heard it, and his conversion, so to speak, was a boon to the whole immunology field. And the world at that Congress, I think, woke up because our Dr. Tom Spira, together with Susan Zola-Pasner of New York University, chaired the session, and the audience overheated the room and overflowed the room and were mesmerized by this. So it finally clicked, I think.
Wow. I guess we'll move on, but I could hear a whole lot more about this because I remember those days, and we haven't heard that much about the immunology community. So not terribly long after this, you began receiving reports of cases of what seemed to be AIDS in blood transfusion recipients. So you were starting to look for transfusion-associated cases, and in December 10th of '82, there was a report of a possible transfusion-associated acquired immune deficiency case in California. Here's where the 20-month-old baby that had died of AIDS after receiving multiple blood transfusions due to Rh incompatibility with the mother. And here a donor with AIDS was identified. Can you tell us a little bit about your investigation of these cases, both before the donor was connected with the child, where the blood banks were concerned about looking for donors? How did that come about?
Well, because we felt this disease had many parallels with other blood transmissible, likely sexually transmissible diseases, be it syphilis or hepatitis B or others, we were all on the edge of our seats. And that's, of course, Curran and Jaffe and myself and Bruce Evett and so on. Bruce was, as you know, a professional hematologist already and inherited the division of host factors, which is fortuitous, I guess, for the population that became involved, the hemophilia population for whom he could speak and interact with professionally. But he and Curran and others wanted to be ready for the first blood transfusion case because it was just bound to happen. And if our hypotheses were correct of transmission routes. So I don't recall when the 20-month-old baby was diagnosed, but I do remember that in July of '82, shortly after my trip to northeastern Ohio, the call came from combined Bruce and Jim Curran to go up to New York and investigate a possible blood transfusion case. We were tipped off, you might say, that this was probably a blood transfusion case in an adult who had seemingly no risk factors, but was now no longer coherent in the ICU to be taking an interview. And doctors Robert Holtzman, Shelley Gordon, Fred Valentine, and HS, or Shelley Lawrence, longtime Dean of Infectious Diseases there at Bellevue Hospital, they called us and said, we think this is a blood transfusion case, which I've often credited them with that. And I went, and to get ready to go, of course, the typical preparation of a shoe leather epidemiologist, whether EIS or alumna, is to hand them a bunch of papers on blood transmissible diseases or hemophilia care in the modern era. So Bruce had Miss Ramsey prepare me in both fields, and Bruce, being hematologist, he knew all about transfusion, so he fully wanted to share in the transfusion field, but Jim knew it was hierarchically crucial to all the other sub-branches, of which Division of Host Factors certainly owned the hemophilia and spouse pairs and children thereof who might be hemophiliacs. So I was working across the task force and Division of Host Factors and keeping both of them appraised at 9 o'clock from New York City every night after a day-long wild experience in the Bellevue Hospital environment. And helped immensely by David Sencer, who took me physically in the Department of Public Health limo to the hospital to have me welcomed to the medical records department and the wards and so on and so forth.
Now, Dave was the commissioner of health in New York by that time.
Yes, he was. By that time, he had left CDC, and in the aftermath of the swine flu vaccine and the unfortunate Philadelphia Legionnaire's disease syndrome, he had either gone directly there or perhaps through an intermediate position. And I feel it was a blessing he was there because he gave those of us who were working there, he considered his children guidance, direction, facilitation, and so he opened doors for me that might have been already closed. But every door that he could open was open, and I worked diligently keeping my staff here informed.
So what were you doing now? You've got a case and someone who's received blood transfusions. What's the process? And the blood banks at that time did not want to share any information around donors. What were you doing when you were investigating?
As usual, the case investigation always involves starting with clinical information. When was the onset of illness? So you can call that the incidence date. And then at least relevant to other cases you know of, either in that same community or elsewhere, the beginning of an epi-curve. So you start putting on a calendar, the St. Louis case that came later, the Ohio case that came before that may be blood transmissible, or the baby in San Francisco that had been reported. And you start creating the epi-curve across the nation or right there locally. That concept then causes you to say, as I investigate and interview the patient, clinicians, family, or other source of information, can I find a realistic source that if this matches HIV as we later know it, immunodeficiency, then is there another cause? Was the gentleman having a secret life on the outside unknown to his wife? Did he use injection drugs? He lived in a very marginal, almost impoverished environment on the western tip of Long Island, not otherwise I'll name. And the answer was no, no, no. And as Randy Schultz described in my work in his book, I Think About This Case, I looked at everything from airflow and staffing of ERs during the man's cardio bypass surgery, during which he had gotten 20 units of blood. Then I got the records of what units and where they came from. 12 had come from the New York metro area, not all New York City. 8 had come from a U.S. Army donation site for the Red Cross over in Germany. I now wanted to follow those, either the federal collected cases or the local ones. I'd start with the local because there was no outbreak yet in Europe, but there was in the New York metro area people we thought had this syndrome. So if I could follow up on those 12 donations, absent any other causation coming to light, I would maybe find that one or more of the donors was an IV drug user, would permit specimens, would show an immune deficiency. We could bank the serum for later someday testing. Well, I got the addresses of the donors from the New York Blood Center, and I wanted to go see them, perhaps in their home, or perhaps call them in to a health department facility like the Chelsea Clinic, which was later used. I was told in no uncertain terms by the blood bank representative on duty that day that I could not actually contact the blood donors. This was a forbidden territory by their own agreements of privacy, respect for the donations. Dr. Sencer was aware of that and I think had to accept that at the time. I had to accept that, CDC had to accept that. But all that information, of course, was saved and shelved, ready to go on a minute's notice. And as it happens in the movie version of And the Band Played On, I think at this point I am shown with a very vigorous debate with Joanna Pendyke, the formal director of the blood bank at that time. I had no such verbal outburst with her, and she was helpful later, but her representative on the day I got there in July said, you may not go further, but here's as far as we can help. Well, December 10, I'm doing a grant research review at NIH in my genetics field. Proud to get to still stay with that field, although getting constantly pulled out into what I would never leave ultimately, HIV/AIDS. And so I get a call from Walt Dowdle and Bruce Evett and Harold Jaffe, and Harold says, Dale, do you remember that baby case? Well, we've just made a connection, and it's going to press. And as soon as that hits, we've told we've shared all this as we did every epidemic report, investigative report that would be an MMWR article. We cleared those with the FDA and other agencies and HHS. So when it hits the press and they know it's coming and the blood bankers have been primed, they'll open their doors. Dale, it's Friday afternoon. Can you be in New York City Monday morning, mid-December? And I said yes. So I reversed from Bethesda, got home, thought I had collected enough warm clothes, but hadn't. Went to mid-December, New York City to follow on. I mention that because none other than our own EIS officer there, Mary Chamberlain, directed me to a place to get some warm clothing at a menswear or something in Manhattan. So she and I went out to the Chelsea Public Health Clinic, where they had already called in the 12 regional donors. We systematically reviewed them with a questionnaire form of CDC, the permission to draw blood, and so on. And as it happened, she and I sat in the room, as we are now, when one of those donors confessed a bit sheepishly that, yes, he didn't want to tell his employer he couldn't really participate in the blood drive safely, so he went ahead and donated. And that donation had really not been too long since he had shared needles with a man who had a strange blood disease that the doctors couldn't diagnose, that they thought might be some kind of weird leukemia, but that's all he knew. And Mary and I realized we were probably, and indeed he had immunodeficiency, not yet AIDS. And so as we gathered that, reporting it back here, of course, we began to accumulate consistent package, handful, and then more handfuls of true transfusion-associated cases. And that subcategory grew over the next few months by leaps and bounds. And so by 12 months later, we had almost 20 of them.
Now, was there any work at that time being done on the immunology from a laboratory point of view of any of these patients?
Yes, CDC had, as I said, been with visionary foresight prepared for exquisite immunologic assessments by Sencer, the parasitology division, and others supporting Dave Gordon and Steve McDougall, et cetera, the rest of us. Because they had that, every single one of these cases was able to be tested. Funding somehow found its way to Stephen McDougall lab and his staff, Janet Nichols and David Cross and others. And as we had our own hands on those test results, we could be credible in national and international fora that this was a syndrome of commonality of immune deficiency, of radical nature like none normally seen before, and that even if it involves subpopulations as dissimilar as babies of drug addicts and hemophiliac elderly men, this was the same immune deficiency with a spiraling towards zero of the T cells.
Now, was that the main clinical test that you were using basically, and it wasn't that easy until I guess the fax counter to differentiate, but the CD4s and CD8s. Was that the primary test that you were doing of a clinical nature?
Yes, the lab had emerged from the very earliest exciting area when, oddly enough, a T cell could be identified by the fact that if you dunked it in, if you separated it from all the rest of the white cells and red cells and plasma, you could dunk it in some sheep red blood cells and little rosettes of little collar of red cells from the sheep would. That odd correlation based on some attachment marker was our functional marker for T cells. If they disappeared, that was an immune deficiency of T cells, or if they're cytotoxic and dead. So we migrated from that over a very short span of time, already by 80, to the predecessor of CD4 test. It was called OKT4 and OKT8, but that CD4 test and CD8. And those tests were at the forefront of diagnostic testing.
Right.
They were only being correlated with clinical disease as we spoke. We were making the history of that. So I don't recall at that moment if FDA had approved them as diagnostic tests legally, but they were fortunately being funded and were making history in our lab, and of course by Dr. Tony Fauci at NIH, who spearheaded their effort.
Wow. Do you feel, what's your thinking about the work that was being done in the immunology lab and under Steve McDougall and others? Do you feel like it was very, it was sort of essential to the investigations that you did?
I think absolutely yes is the short answer. Had we not had that opportunity, I find it hard to believe that CDC would have been able to do what it did for the rest of its contributions in this incredible global pandemic. We absolutely needed that. If we had had to borrow those resources from research grants at another university, or as Don Francis had to do, working with the French in a transatlantic collaboration, or as in retrospect may have been easier with NCI and Dr. Gallo, or the Japanese with their HTLV one, where if we had had to reach out to far-flung labs, we couldn't have done it, and we couldn't have had the credibility.
Yeah.
We moved to the absolute front of the line, and it was only years later that the phenomenal character that Steve McDougall was as an immunologist could be seen for what it was.
Can you tell us more about him? He died, and he's sort of a living legend. Can you say a little bit more about Steve McDougall?
Yes, I believe he came to CDC as a public health service officer, as many other gifted public health service officers did during the Vietnam era. Even if they were not EIS, they got EIS training, and then they went to their respective lab or other assignments. But he came in 1974, as I recall, at the invitation of Dr. Gordon. He was highly trained already, but I don't recall where. He was an absolute quintessential laboratory. He was soft-spoken, had a wry humor, would toss in little jibes throughout the day when it was lunchtime, and he wanted to let some cell culture incubate or some centrifugation happen while we went off to lunch. He would say manger, French for shall we eat? So otherwise I didn't hear him speak French. But we would all troop off and have a fun lunchtime in the cafeteria. He would come back with his white lab coat on, back to his beloved lab work. And he spent many hours with the so-called Cephalodex columns in the cold room that were filtering various serums through and purifying things and so on and so forth that were at the state of the art of immunochemistry and using things to filter out and get pure specimens or to concentrate and get what you want. And so he was the key laboratorian, trained me, enhanced Tom Spiro's training, and along with Linda Martin, taught many of us how to do this. Now, he would not shed his white lab coat. In 1987, he stood before the CDC director in the Auditorium B, I believe it was, and he received the Year Award for the Laboratory Manuscript of the Year, the publication of the year. That publication had put him on the international stage and put CDC on the international stage for having found the exact attachment of HIV, the virus, to the target CD4 T cell, how they connected and why that cell suffered. That was big news in science. He, at that point, I think, anticipated and maybe predated the work even by NIH and others. When he walked to the podium to get that award and accept it, he had only walked out of his lab wearing his white lab coat and then walked back to his lab. That's, get the award, go back, praise his colleagues, they get recognized, and then he's back to work. So my favorite, there are many favorite stories, but my one small one is that in those journal clubs I referred to earlier, he always sat in the back unless he was presenting. He was quiet and soft-spoken, rarely said anything throughout the presentation. When the chalk marks or the whiteboard work was finished or the slides or whatever presented and the speaker finished, he would sit back and he'd say, could I ask you, Dale, or whomever, to go back to slide 2? Is it possible that the publisher transposed the last 2 data columns and that T cell or that immunoglobulin value should have been in the other column? And we looked and he was right. It had been a misprint in the original article that we hadn't picked up. That was the astute insight and just gentle corrections that made him a legend.
That's a great story. You were involved in a number of other studies, but would be just interested in hearing a word or two about those looking at trying to get a sense of the magnitude of this problem. So looking at the prevalence of immune deficiency and clinical abnormalities in hemophiliacs, using HTLV membrane antigens, looking at infection in spouses. Can you tell us a little bit about some of those studies that were done to, again, try and get a sense of how broad-based is this issue?
Well, having already essentially convinced ourselves that it had to be the factor concentrate accountable for most of the severe hemophilia patients' AIDS cases, and having already appreciated the statistical rarity that elderly hemophiliacs present first, long before the teenagers and the young boys typical of hemophilia with AIDS, we felt that the harbinger, the sentinel cases, were these elderly hemophiliacs with a less than robust immune system who, once infected, along with many others, would be first manifest. So the question was, would we study those collections of hemophilia patients treated at, say, Emory or in a New York setting or Colorado setting? Would we focus on studying on those where there'd yet been no cases reported, presumably they being behind in their exposure as a group to factor concentrates and the viremia inherent in them? Or should we start with those communities of hemophilia patients, such as Denver, where it's clear it's already rampant in them by the hematologic findings I cited a few minutes ago and by the clinical lymphadenopathy and so on. Well, it was primarily Bruce's decision that working with colleagues that he knew extremely well, both at Emory and in New York area, that we would get some places that weren't already manifestly prevalent. And he chose those. He first authored those, as I recall, and he showed that it was already there, at least by immune deficits that we and the university clinic labs could test for. But we had aliquots, at least aliquots, of their sera or plasma, and we could ultimately be able to test them when and if an agent's identity came about and the serologic detection technique formalized and made widespread. So we were ready to then be definitive, but we couldn't yet. Now, Don Francis had worked with the people at Harvard in the laboratory of cancer biology there, and Max Essex, his former feline leukemia colleague, and others were exploring this Japanese finding of HTLV, or Bob Gallo's finding of HTLV, and a possible virus. That had a serology. Mm-hmm. That serology cross-reacted with this other sort of responsive, reactive mystery agent. So when serum lighted up from our seemingly ill or immune deficit patients, and not really from the others, we knew we were in the right ballpark, if not at the right seat. Mm-hmm. And so it was explosive news. That was really spearheaded by Bruce and Don Francis and their colleagues and others.
So that was the HTLV.
Well, it was then only called HTLV1 or 2 membrane-associated antigen.
Right.
It was Dr. Gallo later who, in competition with the French, chose to try to call his HTLV3, and their original name LAV.
Right.
But the commonality of serologic cross-reactivity is what led us to feel we've got an agent out there by the tail, not by the head. We're going to keep looking.
Wow. And so when you did look at the prevalence in some of those early studies, was it, well, I guess it depended on the population you were looking at. Were you finding higher levels than anticipated?
It was a spread. As we feared, it was widespread in some communities that had certain products made by certain manufacturers with a lesser rigidity but FDA-approved technique.
Okay.
And perhaps even at a correlation with where that collected plasma processed into factor concentrate had been collected. Mm-hmm. Those centers that were using maybe product from another manufacturer that was maybe heat treated or otherwise treated in some other way, let's call it more stringent, might have been later and behind, although it was hard to say at that point, it was hard to say that any heat treatment had anything other than a retrospective ability to assess its safety, not really a prospective. Because the dilemma was that if the plasma collection network throughout America or the world pays for donations from down and outers who are in inner city urban areas and desperate for cash, and I've known many of those, and they donate for small amounts of cash and donate as often as they can because they get the red cells back and the plasma gets kept and processed, and therefore they'll make more plasma over the few weeks until they do it again. That plasma may have the horrific viremia of their first HIV encounter and viremic state, and that virus may not be yet detectable by anything we have, and the antibody, in fact, wouldn't have been even detectable in the early weeks or months. So they shed a burst of virus that isn't totally into a pool of 20,000 units pooled into a vial or multiple vials. It's inescapable that on a thermodynamic kind of probability basis, some people with high needs and high usage and maybe certain corporate or processing techniques are going to get that virus. Unforeseen.
You were often asked to meet with families at the National Hemophilia Foundation regional meetings. Can you tell us a little bit about that, about the human side of this?
Yes. My career in life and even later life has been associated with appreciating the impact on families of disability and the members of the family. And it started with that occupational injury of my uncle, whose illness motivated me to go into research in medicine. And as I was happy to share what I had learned straight from an up-to-date, inside the CDC, so to speak, horse's mouth, direct information with those to whom it matters most. The patients, their mothers, their spouses or children, and their treating caregivers who come to these regional meetings. I felt a mission to do that, not only to share the facts, but to share it with an empathy that they could recognize I had as a family member. And so when I shared with them the information, I never wanted that message to be one of future fatalism. I wanted them to see what we were doing and the intensity of what CDC and others were doing on their behalf, so that they could sense that they were part of a process to block, stop, prevent, or otherwise move on this tragic avalanche. So it was not good news always. It was sometimes delivered in very somber settings in the middle of the winter after snowstorms impeded plane landings and so on. But I had the opportunity and the honor to be the human face of our endeavors.
We've touched on latency a bit in talking about the hemophiliacs. You were involved in developing and sort of elaborating on this concept of the long AIDS latency period, which was such a landmark issue, and that would come to have huge implications. Can you describe some of the work that led to this finding, and then your collaboration with statisticians to try and get a sense of the impact of this finding?
Well, I haven't mentioned in this setting yet the fact that there were coincidences that occurred that I had knowledge of, let's say pairings of cases where the donor was perhaps still healthy at a time when the baby, an immunologically still young and immature exposee, developed AIDS. But then weeks, months, or years later, the donor who was in perfect health gets AIDS. So we know that the donor had it long before the baby's exposed. The baby has a short latency. the donor has longer. So even if the donor can never be known when he, for example, got infected, we know the date of the babies and we know the date of diagnosis. That's an interval or incubation period or latency. So we knew there was a tremendous span. The same thing was true with the first documented hemophilia spouse pair, two elderly people married in South Florida. The husband gets AIDS. I interview the wife. She, with the help of the treating doctor, and she turns out to have only had a not so distant sexual exposure to him in their late years, and now she has overt AIDS. So it was really, again, a pairing of wide range of incubation periods. Then we look at the blood transfusion information, which I had co-spearheaded with Harold and Harry Haverkos, and then ultimately Tom Peterman and the statisticians. And so I said, we've got the handle on this. I'd had an insight from an Emory University after-hours private course I was taking on epidemiologic methods. I went to statisticians at Emory who used to work at CDC. They had a very gung-ho, can-do, action-oriented style they carried from CDC. And when they told me I needed, my concept was bona fide, that we were vastly underestimating the average incubation period by only seeing the cases that were manifest early in their cohorts, early hemophiliacs, early blood transfusion, we had no yet idea how many had been infected, nor where the halfway point would be. And I was looking at where the halfway point is and where the inflection point is in the curve and so on, each year getting bigger and bigger cohorts of transfusion aids in New York and so on. And they said, you need mathematical modeling. So I turned to the CDC statistician who had done a remarkable job, very young, early careerist, named Dr. Kung Jong Lu, originally from Taiwan. He had worked on the linkage between clusters of blood transfusion cases with their respective donors and showed in that statistical argument that if you take all the AIDS cases and all the infected, suspected donor clusters, they shouldn't distribute where one AIDS case was always associated with 10, 20, or more blood transfusion donors, only one of whom had the risk factor of immune deficiency or IV drug use or gay lifestyle, etc. He had done a really statistically remarkable thing that we later published and presented. I went to him and I said, I don't know if this is in your field. It's way beyond my minor in mathematics. Help me here. He looked at it and he brilliantly chose from all statistical models one that had never been used before for health issues, only an industrial application. Little known to us statisticians at CDC, called the Weibull Distribution. I would not want to try to explain it now. So as the originator of the concept that he then made manifest, and as an epidemiologist of the task force, I could be the interlocutor with the task force meetings and with ultimately, of course, Bruce and the hemophilia presentations, and then ultimately the International Conference on AIDS, where it was very fully presented and well covered by the press. The outcome of that, to my surprise, was only a short while later was considered so well known that the columnist, I think Ann Landers, was putting it in her advice column to the world that we must recognize that it could be a long time between exposure and actual AIDS manifestations. But the horrifying thing was that the model said that based it on only 20 or 21 cases then, none of whom had over 5 years, most 2 or 3 years, that we were looking at a disease of 5 years or maybe 10 on average. What does that mean the future holds? I realized that we were riding a tiger, that the world, including the sub-Saharan Africa, that the gay population and the artistic population of our country, the hemophilia patients that I had been facing with incremental news, we were facing a national calamity that would change public policy, public insurance funding, the arts and sciences. And so this was a revelation without an ability to prove it. There was no serologic test and unaffordable to test everyone in America. So we were really caught, tragically, until further cases came, and thank goodness a serological test came available that could cement the facts.
Well stated. Very, very frightening. Well, it sounds like you hit a lot of the high points in the work at CDC. How did your experience with AIDS at CDC end up affecting your future career choices? Eventually you left CDC.
Yes, well, perhaps I haven't said it explicitly, but the watchword for all of this was teamwork. While here, and as each of these dramatic stories were unfolding, from those in early 81 through the work you were doing in 81, 82, and the hemophilia in 81, 82, 83, and so on, each was cascading at an explosive rate that I can only liken to maybe a few other outbreaks that Ebola and otherwise, SARS and Zika and so on that we know of today, or the space shot or World War II, things that had to come together across all disciplines to quickly combat a threat of global immensity. So as the team worked, without there being hardly any egotism at a pathologic level, we were called on to really implement each action as seemed right then necessary. And we had the CDC can-do atmosphere from past outbreaks and past issues of national importance. So I thought in 1981 that I would be spending a career in the academic public health interface, clinical interface, of understanding why disease manifests in some people as scarlet fever and others as just the sniffles, or death from measles in Africa and only a rash in the United States, or permanent arthritis as an outcome of certain infections, while other people had only a little rash and then over time it was gone. I thought I would be dealing with genetics of immune response and why our human family around the world is both dissimilar and similar, and how they spoke to the epidemiology that CDC was avant-garde in. Well, no, that era ended. My lab space had to go for T-cell testing and other testing. My career in publications of everything onto even mitochondrial DNA and Amazonian Indians and Siberian people, all that stopped. The issues of antiquity of humanity, all that stopped, and it was AIDS, 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 which ultimately carried me toward NIH and AIDS vaccine work. My other work was here at CDC in the then new exciting work of cellular immunology, comprehensive immunology, and vaccines. And we had big, exciting projects right up there with NIH and academia, but our influenza and pneumococcal studies, fast as they were, had to stop for AIDS. So I had to go around the back to get into vaccines again years later, but everything built on another thing. And as I've often said, those projects you really didn't want to do, when you get into, you wound up gaining another insight or credential that prepares you for a future opportunity.
You have had the opportunity to see both agencies, and I won't ask you to compare them because they're so different. But when you look back at CDC's response, you've had so many positive things to say about how CDC works and how it was perceived. Were there any aspects of the work you were involved in where you thought maybe CDC could have done a better job?
I would say none that I can feel confident to make, because for every possibly negative insight I might have on operational things that took place at the time, there was some antecedent reason why we did it that way. It may have been our budget was so constrained we couldn't have done more, funded more, or that it took another several months for the unfolding epidemic to demonstrate that a new construct of response team, be it task force or new laboratories, et cetera, be assembled and staffed. The saddest thing, I think, is that we didn't have the almost instant availability to bring online here, the way we had the antecedent T cell work and immune deficiency work, bring online the retrovirology or lentivirus expertise that ultimately led those devoted to that, be they France, Netherlands, and certainly Dr. Gallo and others, to break open this disease. There were inquiries I made to the lab of Dr. Gallo early on when I saw that he was following or leading some of the work done by the Japanese in adult T-cell leukemia lymphoma virus, that I felt he had the lab resources. But, you know, I was an unknown from CDC, and he was busy in the lab. He didn't return the call, although I gratefully learned others tried to solicit his involvement, like I think Jim Curran and others. We didn't have that lab, so Don Francis had to reach out to his Pasteur Institute colleagues. My real sadness is that, best is that the skills happen in the labs best prepared to do it, and clearly history unfolded to make those labs produce for the world's benefit. But CDC had done such an investment and credible job that I believe had a nascent protocol. We began here in February of 1983, 9 months or 6 months before the French announced at the Kyoto meeting that they thought they had something. And certainly a year and a quarter before Dr. Gallo announced his seeming finding. Had we gotten beyond the first snafus or problems in our lab bench work that I and Steve McDougall and Paul Fiorino attempted to isolate that virus, I think CDC might well have been a contender, so to speak, with that. And had they done that, a lot of the acrimony of, Nobel Prize work and attribution and so on and so forth that we weren't even a part of, but had to be proud did get done by someone, we might have been a part of that. Mm-hmm. And I think it would have been nice if the late Stephen McDougall and our colleagues of that time had truly been able to claim small credit for the actual discovery. We were close.
Thank you so much.
You're quite welcome.